All right, so with no further ado, kind of jump into things here. So really we define IBS by the Rome 3 criteria, which was kind of a consortium of gastroenterology specialists that came together and came up with this very specific criteria for the diagnosis. And really kind of simply, it's recurrent abdominal pain for at least 3 days out of the month, and it's typically gone on for 6 months or more, and it's associated with any two of the following. Typically, the onset is associated with a change in the form of the stool or the frequency, and there can be an improvement in defecation. So really, when we kind of think about this even more simply put, you kind of need 3 things here. Pain, there's usually some component, and in most patients, it's lower abdominal, or what we call kind of periumbilical, or around the umbilicus. There's a change in bowel habits, and there's some sort of chronicity. And as mentioned in the prior slide, the chronicity means that symptoms are typically present for at least 6 months or more. Well, the next question is kind of who gets IBS? And you can probably guess by looking at this slide, really anyone can get IBS. Doesn't kind of spare any age group, any ethnicity, any sex, really anyone at any age at any time can get it. I'll kind of touch on it now and go into it a little more later, but typically IBS is diagnosed earlier in life, but again, it can certainly be diagnosed in later stages. And to look more specifically at the epidemiology, really 10 to 20% of adults will have symptoms of IBS, which is really quite a large proportion. As mentioned, it affects all races throughout the world. For reasons that are not entirely clear, women are diagnosed more commonly than men are. And the diagnosis, as I kind of mentioned just a moment ago, is typically made earlier in life, usually before 35 years of age, but again, I do stress it can clearly occur at any age. Well, what causes IBS? Really the first thing I'll say about it is we don't entirely know. There's a number of different theories out there, and in all likelihood, it's really a multifactorial, meaning really different processes kind of go into the overall pathophysiology. One of them being visceral hypersensitivity, and that's really just an increased sensitivity to gut distension, whether that's from food, gas. It doesn't really make too much of a difference, but clearly patients with IBS seem to sense these things somewhat more intensely than other patients do. There has been some support for gastrointestinal motor disturbances. Some patients, the small bowel or colon seems to be slower, meaning it doesn't quite move as fast as in normal subjects. In others, it moves too fast. There is some more emerging data about something called bacterial overgrowth. And that's particularly bacteria in areas of the bowel where most patients they're not, and that's usually the small bowel. Of course, in all of us, there's bacteria in our colon. But in certain patients who get bacteria in the small bowel, it can cause breakdown of food products. It can cause gas, bloating, diarrhea in some patients. And actually, some of the newer therapies are targeted towards this, and I'm going to talk about that in a little bit here. And then lastly, there's some question about inflammation. Really, when we think about IBS, we don't really think that inflammation is a major component. But, you know, with the belief that in some patients they can have what's called a post-infectious irritable bowel syndrome, meaning typically after a bout of commonly like a bacterial, colitis, typically 6 months later they can get symptoms of irritable bowel syndrome, which is more often like a diarrhea predominant. So there is some thought that inflammation may contribute in certain patients. Well, when we think about IBS, how do we classify it? And it's really pretty simple, actually. We think of really 3 different main subtypes. The first main subtype is constipation predominant IBS. Those patients typically have more difficulty with passing stool, feelings of fullness, hard stools, decreased stool frequency. The second opposite would be diarrhea predominant. Those patients typically have more loose stools, more frequent stools. They can have symptoms of bloating, as can patients with constipation. And then the third subtype is alternating constipation and diarrhea. These patients really have a hard time telling me or telling themselves, is it more constipation or diarrhea? They really flip-flop almost 50-50 between the two. And then I will kind of, a few caveats here will say, not all patients fit strict criteria for all the above, and those we kind of put into a category called IBS unsubtyped. And as mentioned above, with both constipation and diarrhea, bloating can really be a predominant symptom. It can be really a major component of a lot of patients' troubles. It's back up here, but it's not up there. That it?
When you have a blue bell like that, it's no good.
That's true. Okay.
It seems like it's the. It's just very, yes.
Time for the musical interlude.
If I could dance, I would. I don't want to see me dance.
I could ask you,
Well,
sorry,
no problem.
ask my question in the meantime. You know, I had esophageal cancer, and I'm allergic to Percocet and Darvocet. But once in a while, in a very long...
I'll breathe like very shallow.
Oh,
Don't worry, we plenty of time to talk.
Or not at all, maybe. Okay. All right, so kind of jumping back to where I just kind of mentioned a little bit about the subtypes and how Blvd can be really a dominant symptom in a lot of patients. Some of the treatment will get into how we help alleviate that symptom. And this just is a little breakdown that really, there's really no predominant subtype, meaning most patients, there's no group of patients that typically have more IBS C or D. It's really kind of a pretty even breakdown when you kind of look at all patients with irritable bowel syndrome. Well, how do we diagnose IBS? The diagnosis really is kind of based on a clinical history and exam. Initially, when we first started talking about IBS and started diagnosing IBS, we considered a diagnosis of exclusion. That's really kind of an antiquated thought. I mean, some physicians may still have this belief, but in all honesty, it's kind of a thing of the past. And these kind of exhaustive workups of, extensive laboratory evaluations, invasive procedures, and such are really no longer necessary in the vast majority of patients presenting with symptoms of IBS. The one caveat, though, is if patients do have what we consider GI alarm symptoms, things such as bleeding, weight loss, anemia, fever, those sort of things do need further workup and often do merit more invasive evaluations with labs, with possible endoscopy, with possible imaging. And a question I always want to address, particularly with you guys and certainly with all the patients I see with IBS, is kind of what does IBS mean to me? What does it mean to my overall health? How is it going to affect my lifespan? These are very important questions. And one of the first things I do tell all my patients with IBS is that while it may have significant quality of life impact, it's overall considered a benign condition, meaning there's no increased risk for things like colorectal cancers or other malignancies. The lifespan of patients with IBS can be just as long as anyone else who's otherwise healthy. And importantly, what I try and stress is that really symptoms can wax and wane over time, and many patients can actually resolve. It doesn't mean that because you were told you had IBS when you were younger that you're committed to having symptoms for the rest of your life at all. And sometimes we don't know why symptoms go away, but they do in some patients. Well, let's kind of delve a little bit into the treatment for IBS. I'm just going to give you kind of a brief overview. I'm not going to talk too much about every one of these treatments, but I will focus on a few of them, particularly some of the newer treatments and things that I find useful in my clinical practice. And one thing I will stress, all of our treatments are really targeted towards the subtype of IBS patients have. So we target our treatment based on whether they have diarrhea predominant irritable bowel syndrome, constipation predominant, or more of the kind of pain, bloating symptoms. And for diarrhea, we can use things as simply as loperamide or Imodium, things you see over the counter, might use for when you have a viral bug or something like that. Antibiotics are something that's new, and I'm going to talk a little bit more about. There's kind of some emerging data about probiotics, which I will touch on as well. Moving over to constipation, things as simple as fiber or psyllium, which is just a form of fiber. Osmotic laxatives is kind of the second tier, if you would call it. And then kind of the third tier would be things like lubiprostone, which is a prescription medication, or Amitiza, some of you may know it by, which I will talk about a little bit later on as well. And then for kind of pain predominant or bloating symptoms, things like antispasmodics, Levsin, older medications like Librax. Antidepressants are something that can be used for patients, and I'll touch on that as well. And then lastly, elimination diet probiotics.
May I ask
Of
a
course,
question?
absolutely.
Okay.
Please feel free to interrupt, by the way, at any time.
When
This
you
is
talk
interactive.
about abdominal pain,
Uh-huh.
does that also include cramping, considerable cramping?
Absolutely.
Is that synonymous?
Yeah,
pretty much?
absolutely. Pain, cramping, everyone, pain is a little bit different, but
Okay.
clearly cramping pain is something that can be very classic for the pain we describe in irritable bowel syndrome.
Thank you.
Absolutely. So let's talk a little bit about what's new for IBS, since this is, kind of what you guys probably came for, and I'm going to kind of focus first on IBSD. What's new is, as I touched on a moment ago, is a non-absorbable antibiotic called rifaximin, or Xifaxan, and it's been found very effective for the treatment in irritable bowel syndrome diarrhea predominant. Well, how did we learn about this? Well, really the study was done, very well done study in the New England Journal of Medicine. Just kind of give you the brief details of it. Again, it focused on patients with IBS, predominantly without constipation, and most of these patients had symptoms of diarrhea and bloating. The dose was 550 milligrams given 3 times a day, and of course they looked at it versus a placebo, or meaning like sugar pill, or a pill that doesn't have any actual meaningful treatment for IBS. And it was done for just 14 days. And really the end point was to look at, did these patients get relief of their IBS symptoms?
What I have found is that when you stop diarrhea, it goes to constipation. Now, what's been your experience in what you just mentioned of that happening? Because like Imodium, some people take Imodium, they're going to be constipated for 3 or 4 days.
Okay, let me get to like specific questions at the end. Does that sound okay?
Based on what you say of this rifaximin.
Yeah. Let me finish the slides
Sorry,
first.
I'm
No,
sorry.
that's okay, because I think maybe I can touch on that a little bit more at the end when we have a little bit of time for questions. But for patients with irritable bowel syndrome diarrhea predominant, rifaximin was effective up to 40%, which in all honesty for an IBS treatment is actually quite good. And it relieves symptoms of bloating, pain, or cramping, and their alteration in bowel habits. And really this effect was sustainable after 3 months. And if you had a response at 3 months, you were likely to have a sustained response as well. And I am going to talk a little bit more about my personal experience too with it in just a moment. And here's what I would say about it. In my experience, it clearly does work for patients with bloating and diarrhea. Again, this is my clinical experience. I've used it a fair amount. In most of my patients, I've noted that the relief lasts longer than 3 months. Remember, these are clinical trials that I just referenced, and it's often very stringent criteria. So often in clinical practice, we'll see better results sometimes than you'll see in the literature. And also what I found in patients who did have relief, but then their symptoms kind of returned, meaning, we improved the bloating, we improved the diarrhea, but they came back to me 4 or 3 months later and said, well, doc, these symptoms are back. Retreatment actually with the same dose for the same duration actually was effective, and this is also evidence-based as well, so there is some literature to support retreatment. And one thing I will say about it before moving on is it was very safe. There were very few adverse side effects from it, so it's a very well-tolerated treatment. Well, what else works for irritable bowel syndrome? I know you had mentioned, sir, a little bit about the Imodium. Imodium is effective for decreasing stool frequency, but for patients with a large pain component, it's really not going to touch that too well. They may need to add an antispasmodic such as Levsin, to kind of target that. What else can help with symptoms of IBSD? Well, the tricyclic antidepressants, which are a class of medication which are targeted for depression, but we found that they can actually work well for patients with diarrhea-predominant IBS. Again, the exact reason we don't know, but they can be somewhat constipating. So if you take someone with diarrhea and you give them something that's slightly constipating, you may alterate their bowel habits to quote-unquote more normal. So that's beneficial. And for patients with irritable bowel syndrome who may have also some underlying depression, anxiety, these medications can also be effective. What is one important thing I'd like to mention to all my patients, and I'll mention to you guys as well, is that we start very low dose. We don't typically use the doses used in depression, so some of the more significant side effects you don't often see, and we really don't go up to a high dose at all, and we slowly increase it over a period of 3 to 4 weeks. This is just a little quick slide. I won't, spend too much time on it, but it just kind of looks at the quality, of evidence for, why we do these things. Do they work when you actually look at the data for it? I've kind of talked about, what works, and this just kind of reinforces some of those things. Again, as stated, Imodium will work for the symptoms of diarrhea, urgency, probably not too much effect on the pain, as mentioned. Antispasmodics can be very good for pain, but if patients really have a lot of constipation or diarrhea, you're going to need to specifically treat that as well. As mentioned, the antidepressants, again, very good for global symptoms of pain, may help some with the alteration of bowel habits, particularly if diarrhea is a predominant symptom. And then lastly, antibiotics get a very high quality of evidence. This is really referring to rifaximin. It's, again, very safe. It seems to help the global symptoms of pain, bloating, and the diarrhea. So it's an effective new treatment that we have. Well, to kind of segue a little bit into its kind of sister, IBS-C, or constipation predominant, what's new for that? Well, this new medication I'm going to talk about is really just recently approved within the last few months for IBS-C. It's called linaclotide, or Linzess is the trade name. Again, it's a new medication recently approved for the treatment of constipation predominant IBS. It's been shown to significantly improve symptoms of pain and bowel symptoms. So much like rifaximin for IBS-D, not only can it improve the frequency of the bowel movements, meaning patients who are constipated often will have more frequent bowel movements, they'll have less straining, but their bloating, their pain, their just overall, kind of quality of life has shown to be improved with this medication. And much like rifaximin as well, there really were no serious adverse side effects reported in the clinical trials. Well, what else works for IBS-C? I talked about this a little bit in the overview, but lubiprostone or Amitiza at the lower dose, there's two doses. The typical dose for IBS is the 8 microgram dose given twice a day. It improves the pain, the bloating, as well as the stool consistency. One thing I will mention about lubiprostone, I do think in clinical practice it works quite well. If you look specifically at the clinical trials with it, it's very modest. Again, these are very stringent trials, and again, looking at them versus clinical experience is often different. So I do find for it to be very effective. And like the other treatments, I found it to be very safe. The only really issue I see with it is patients initially when starting, you can get some nausea, vomiting, and that's often relieved if the medication is taken with food and after a few days of treatment. So to talk just a little bit about, again, my experience, what I think works. Clearly, Amitiza, as mentioned, works. I kind of touched on that I do ask all my patients to take it with food due to the nausea and vomiting. Fiber, in all honesty, this does not have a major impact on IBS-C, particularly for patients with a strong pain component. Many patients it can actually make it worse because it can cause increased bloating, distension. So in very kind of mild IBS cases, it may be helpful, but in patients with a lot of pain, severe constipation, it's not too helpful. And then just to kind of talk a little bit about one other laxative. It's an osmotic laxative, Miralax. Much like loperamide, it will improve stool frequency, but does not have a major impact on the pain component of IBS. And this, again, is just a little bit of a breakdown here. I think we kind of touched on most of these and how they work and what they work for, so I won't spend too much more time on that. Well, let's talk about some of the kind of non-medication things we use for IBS, diet, probiotic, etc. There's been a lot of, it's kind of a hot topic in irritable bowel syndrome and really just in GI in general, these kind of quote-unquote elimination diets. One thing I will say about them is that a true elimination diet is typically done based on really very specific laboratory testing, often done through an allergist. This hasn't really made its way into what I consider like kind of mainstream treatment of IBS. But in patients who are very motivated and are seeking a possible allergic component and are very, again, motivated to maybe do an elimination diet, there may be actually some utility in considering an allergy referral for those patients. For reasons that are not entirely clear to us, gluten, again, another very hot topic, can cause symptoms in patients with IBS without true celiac disease. Celiac disease is patients who have clinically proven, typically by endoscopy and or by lab, celiac disease. So these are irritable bowel syndrome patients who don't have celiac disease proven, and for whatever reason, by eliminating gluten in their diets, they often have improvement in their symptoms, pain, bloating, often diarrhea. Why this is, we don't know, but I'll also say it's not clear to us yet that we can formally recommend this for all our patients because it's such a restrictive diet. Again, it hasn't made its way into mainstream yet. And then lastly, just a very low carbohydrate diet has been shown to be effective, particularly for irritable bowel syndrome with diarrhea. It improves quality of life, pain, stool consistency. Again, there's not large amounts of data for this, but it's starting to emerge. So these are kind of hot topics in terms of diet that we're learning more about. Okay, well, what else works? Exercise clearly has been shown to improve symptoms of irritable bowel syndrome. We mean exercise, we typically are talking about some sort of aerobic exercise, 30 minutes, typically 5 days a week. Stress reduction, clearly, yoga, meditation, there has been, some small studies that have shown improvement in irritable bowel syndrome with both of these modalities. And then lastly, acupuncture. And just for a few final thoughts, one thing I will say is IBS is clearly one of the most common problems encountered in GI practice, if not the most common. I see it at least 1 to 2 to 3 times a day in my practice. Effective communication, in addition to all the treatments, all the diets, all the recommendations you can make to your patient, really effective communication between, the physician and the patient, setting goals, really understanding that this is, a condition that, may cause symptoms from time to time, but really can be manageable either with medication, with exercise, with stress reduction, etc. One important thing I realized too, and I continue to be humbled by, is that not all IBS patients are alike. What works for one patient may not work for others. As a physician, I have to keep an open mind in terms of, different treatments work for different people. And then multidisciplinary care is probably something we're going to, really start, thinking more about in IBS patients. Allergists, nutritionists, psychiatrists, a good primary care physician is really key to the treatment of patients with IBS and really successful treatment in IBS patients. So with that, I'm going to kind of open it up a little bit to some questions that you guys may or may not have, and we'll go from there.
When you spoke about diet, you didn't mention something that I've been reading a lot about, and I want to know your thoughts about this. I've been reading that certain combinations of food are bad for IBS. The combinations of food that I've been reading about is that don't mix in the same meal starch and proteins. Don't have fruit either at the end or with the meal. Have it separate, maybe an hour before you eat or hours later. Have you come across that in your practice as substantiated? Because it's not a new theory. In other words, it started in 1900 by Dr. Andrew Hay, who had a very serious gastro disorder, and he started separating his starches from his proteins and didn't mix them at the same meal, and he cured his own disease. So I'm just reading about it.
Sure.
I'm starting to try it a little bit, especially the fruit part of it, because I'm a big fruit eater, and also I'm not eating potatoes when I eat a steak. I'm not eating pasta when I'm not having spaghetti with meatballs. I have spaghetti separate, I have meatballs separate. So what are your thoughts on that?
Well, it's totally anecdotal. There's no medical literature to support that, just to kind of touch on that. And like I say, even the elimination diet is something we're not entirely clear is going to work for everyone. So, I mean, it's kind of like a case study. You take one, any person can kind of do one thing and tell you that it works, So it's anecdotal. Now, again, what I say about IBS and I stress, and that was one of my last slides, again, everyone is different, okay? If certain dietary things work for you or you seem to improve your symptoms, there's nothing wrong with it as long as it's safe. And clearly there's nothing unsafe about that. And it kind of brings, to mind the bigger picture of IBS is that it's a totally symptom-driven disease. Okay, like I say, there's no organic really pathology that we're entirely aware of now. So if whatever you do, whether it's dietary, whether it's lifestyle, that seems to improve your symptoms, I'm clearly in favor of it as long as it's not unsafe or there's no undue harm. So to kind of get to just kind of in summary, that would be anecdotal, but at the same time, I would see nothing wrong with it.
Thank you. It was a wonderful PowerPoint presentation.
Thank you.
What do you know about dicyclomine?
Okay, good question. So dicyclomine is an antispasmodic. It's also known as benzyl. One thing about dicyclomine is a typical dose is like 4 times a day, and it's kind of like a medication that we kind of give typically on a daily basis. So some doctors will kind of tell their patients to use it as needed. The other kind of antispasmodic is called Levsin or hycosamine. So they're similar. The difference is Levsin's an as-needed medication. My preference is, again, because it's symptom-driven, I don't like to commit my patients to an everyday medication, okay? Because they may not have symptoms every day, okay? And really, in anything, in any sort of treatment, the lowest, most effective dose is what should be everyone's goal, patient and physician. So I typically start with as-needed medications, and menthol can be used as needed, though it's not really indicated as such. I typically use the Levsin because that can be, prescribed on an as-needed basis. It seems to be a little faster acting. Again, that's my experience.
Now, what was the name of that?
It's hycosamine is the kind of general name, but Levsin, Lvsin. It's like a sublingual preparation. You can go on.
Lvsin.
Yes, yeah, and it's, again, same class, antispasmodic, can help with the pain, cramping component of IBS in some people.
Are people with diabetes more prone to IBS?
Not that I'm aware of, no.
Okay, the other thing is, most of the doctors that I go to say drink a lot of water all the time. Does water help with regular bowel movements?
No, I mean, there's, right, again, that's anecdotal, it's kind of like, like fiber for diverticulosis and stuff like that. It hasn't really proven, in medical literature, to really make a difference drinking a lot of water. Now, drinking a lot of water healthy is good for you, so it's certainly a healthy practice. It's, as long as you're not being excessive with it. There's nothing wrong with drinking a lot of water, though for most people, with IBS, more constipation predominant, which I believe you're referring to, drinking a lot of water probably won't make too much of a difference. But again, if you notice a difference with more water, there's certainly nothing wrong with it. It's
Well,
a
it
healthy
keeps you
practice.
hydrated.
Exactly, that's my point.
If
It's
you
a
go
healthy
for a blood
practice.
test and you're dehydrated, they won't get any blood out of you.
I don't know about that, but it's
Well,
tough.
I
You have to be pretty dehydrated.
It's a hard stick if your veins are bad.
Yeah, exactly. That's possible, for sure. Okay.
I mean, I've had IBS for years. And, I went on an Atkins type diet,
Okay.
and it was great. I mean, I didn't have an attack of anything for a couple of months.
So,
And then when I went back to my normal eating carbohydrates, I went back to the IBS. What I'm using now is Blvd,
okay.
and I find I take 20 milligrams at bedtime,
Right.
and it's great.
Good. So, yeah, you kind of bring up two good points and kind of things that I touched on that are effective. Low carbohydrate diets in some people can be effective, and that's something we're learning more about. Blvd, just for the rest of you guys, it's one of the tricyclic antidepressants, which I didn't speak about specifically, but again, it's one of the medications that can be used in patients, typically more diarrhea predominant, because it can be slightly constipating, and it can also have effect on the pain modulation, so it can improve the cramping and such. And again, using lower doses, like you're using, 20 milligrams.
Well, I
which is-
tried 10 milligrams, and
That's an
then
incredibly
I
low
moved up to
dose.
20.
Right, exactly, and it's still a very low dose.
Any long-term effects with Blvd?
I mean, again, they're overall safe medications. These aren't, some like you get elevated liver tests. Again, these are rare things. Like any medication, you see a laundry list of things. But overall, they are safe, particularly in the low doses. They are safe. I certainly have not experienced any significant adverse events in the patients I prescribe this medication still.
If you are in a sort of siege, I'm going to say, and you take several Imodium over a course of days, is that okay?
Yeah, I mean, you just gotta be careful that you're not going over the dose. I think the dose is like 16 milligrams a day is kind of the maximum dose. So yeah, no, there's nothing wrong with it as long as you're not exceeding that dose, okay?
I mean, I'm asking that, my daughter has very bad IBS.
Yeah.
And
I-
she uses a lot of it, and
Well, I guess what I would say
concerned
is
about it.
she may need something, something else in addition,
Right.
that's, if she's having to use it a lot, you'd have to kind of take a step back and say, wow, this probably isn't, effective, there may be something better out there, such as a tricyclic antidepressant, maybe a trial of rifaximin, there are other, therapies out there that, may not
Is
commit her to using.
Lomotil better than Paramount?
I'm sorry?
Is Lomotil better?
There's no, it's very,
Same
same thing, I mean, it's just a different type of
I
anti-diarrhea.
use Lomotil when I get a...
No problem with it. Again, much like, Imodium, it can help.
What about gas X?
Nothing wrong with it if you have a lot of bloating. And, you know, a lot of bloating in patients with irritable bowel syndrome is often dietary related. You know, foods that are high in gas, high in fiber can cause significant bloating. And again, that kind of goes back to this theory, we think that there may be some small intestinal bacterial overgrowth in patients where these food products are being broken down earlier, you know, in the intestine and typically. So that's something to consider, but nothing wrong with it. It's safe and using it again on as-needed basis.
What about lactate intolerance?
Good question. So, I mean, that's, lactose intolerance is lactose intolerance, meaning, you know, you can get bloating, diarrhea, gas when exposed to dairy products. Patients can develop, you know, lactose intolerance as we age. We kind of lose our ability to break down lactose, so that's notable. But it's not, it doesn't, you know, cause IBS per se. Now, it may make, if you have IBS, you know, D, you know, if you had it your whole life and things are worse as you get older, well, there may be an element of lactose intolerance if you notice things are worse with dairy.
What's the best thing to use for lactose intolerance?
Just lactase pills. It's just pretty much, you can take a pill that kind of is the enzyme that your body's lacking to break it down. No, BNO is like Gas X. Lactase is a specific pill you can take which will help break, which provides kind of the enzyme your body no longer has to help break down dairy products.
Should we
You can get it over the counter.
Kelly told me about Helen.
You guys have it, I'm sure, right?
Yes.
Yeah.
We have. I just want to ask you one more question.
Oh, of course.
Probiotics.
Good question.
Is it something
It says
that we all should be on, so to speak?
Good
If
question.
there's difficulty?
Yeah, good question. So probiotics are something that's kind of emerging too in terms of irritable bowel syndrome. The data is, there's data out there. The problem with it is that there's a lot of heterogeneity, meaning there's so many different types and strains of bacteria and probiotics, it's hard to make definitive conclusions about them. There is one strain, it's called Bifidobacter infantis, and I believe it's in a line that has shown in patients with more diarrhea, irritable bowel syndrome, you know, to perhaps have some effects on decreasing their diarrhea, their pain, etc. Again, it's a very small study, okay, and there's more and more studies going on as we speak. So you're going to see, there's going to be a lot more literature about IBS. So I do think as we kind of narrow things down and isolate some of these strains, we'll figure out which specific ones do and don't help. But that is one that there is some data. I would say about probiotics now is that they're probably not considered standard of therapy yet. Again, because you don't have enough literature. They're more complementary, which means, you know, we can still use them, but I don't typically use them as a first line. But in the future, you know, they may very well, if the data supports, you know, their use, they may become standard of care. They're overall very safe for the most part. There have been a couple of reported, I think, cases of fungemia, which, you know, kind of scary. I'm sorry?
Anemia?
Fungemia, like a
Fungemia.
massive like blood fungal infection to be life-threatening, but that, you know, but they're overall safe. I mentioned that just because it is noteworthy. There's like 2 or 3 cases reported, to my knowledge. But overall, they're very safe for people who are otherwise immunocompromised or things like that. The downside to probiotics is really now is their cost. They're expensive. Okay, so that was what I would say is the downside to them.
What can you do for severe constipation?
With irritable bowel syndrome or just severe constipation? When I say irritable bowel syndrome, are you have with a pain component to it, like this has been going on for months with pain, the pain gets better when you go to the bathroom, or it's just you have a really tough time having a bowel movement and there's not a significant pain component?
Some stomach pain.
Okay. So the 2 main treatments, you know, just to kind of, I'll go back here a little bit. I think this slide will be helpful to you. So these are kind of the treatments, you know, roughly available that we use for irritable bowel syndrome constipation. The simplest thing is fiber, okay, which again, in my experience,
I drink a high fiber cereal in the morning.
doesn't help too much, right?
Yeah.
Exactly. So you're like most people. Okay. So then the second tier would be like an osmotic laxative called Miralax. Okay.
I take it. Didn't work.
Didn't work. Okay, no problem. So it's okay. It's okay. Yeah, plenty of patients just like you, no problem. And so then the 2 other medications, you know, again, the one I talked about, it's brand new. That's it. Okay, linaclotide. Okay, just came out, so that may be something to consider. The one that's been out a little bit longer is Amitiza or lubiprostone. Okay. So those are things, you know, worth considering if you have a gastroenterologist, talk to them about.
Yeah.
If you don't, seeing someone,
Lindsay.
discussing it with them. So if you've tried both those things and haven't had significant relief, you don't have any other concerning symptoms, you've had a colonoscopy and such, that I don't wanna like
Yes.
minimize that, okay, good. Okay, without any like significant bleeding, unintentional weight loss, and this, is IBS, well, that's just fiber really. That's if she hasn't had a response to fiber, that's probably not gonna help too much. But these other medications might be something worth,
Not a
considering.
little prune juice.
Yeah, again, it's just like, it's fiber, really. I mean, for some people it works great though. I mean, I have nothing wrong with it. My guess is it wouldn't work for someone like you who've had kind of not great response to other.
Because I know my cereal has about 14 grams of fiber.
Yeah. You may actually want to just, I mean, if you get a lot of, do you get a lot of bloating and cramping?
No, the truth is,
Okay.
it doesn't even bother me.
Okay, all right, then I was gonna say if you did, the fiber may actually make things worse, but
That's
probably not.
What about something like Mucinex and stuff like that?
I was thinking about
You
that.
mean Mucinex? Oh, not Mucinex, I.
Yeah,
No,
You mean
Metamucil.
the ENT docs will be here next month. Okay.
Metamucil, right.
What's that?
Metamucil.
Oh, Metamucil, okay, yeah, good question. So Metamucil is just a fiber supplement, okay, it's like psyllium. So again, for what I consider very mild, just trouble with, bowel movements a few times a week, maybe straining, that sort of thing, without a major pain component. It's certainly worth trying, it's obviously very safe, it's inexpensive, if it works, nothing wrong with it. Again, in most patients, I don't have a great experience with it, but it is certainly worth a trial. It's simple, it's safe, it's easy, cost effective.
Thank you very much, Doctor.
My pleasure. Thank you guys for